All right. Good afternoon, and thank you all for being here. We're going to go ahead and get started. I want to thank you all for being here today. My name is Rose Locklear, and I am the Program Manager at the Oregon Office of Rural Health that is responsible for the annual Forum on Aging in Rural Oregon. And this year we were unable to have a live forum in person to see all of your faces. However, we are taking some of the sessions and offering them virtually as webinars, and this is one of those presentations. So before we get started, I want to take a moment to thank our partners who have stuck by our side through the whole coronavirus pandemic. That's going to be our Central Oregon Health Council, Pacific Source, St. Charles Health System, Samaritan Health Systems, O4AD, Oregon DHS, Aging and People with Disabilities, Adventist Health Tillamook, Peace Health, Gobi, and Columbia Memorial. So a few housekeeping tips and tricks before we go ahead and get started. Audio and video for participants is muted to keep the background to a dull roar. If you would like to ask a question, please use the chat function, and I will read your questions to the speakers at the end of the session. Presentation slides are going to be available at the link here on this slide, Oregon Office of Rural Health's Annual Forum on Aging webpage under webinars. And this recording will have closed captions. So without further ado here, we are going to present to you all today Hospice and Long-Term Care in the Year of the Virus by Dr. Michael Noer and Lee Garber. Dr. Noer is from St. Charles, and Lee Garber is from Regency Rehabilitation Nursing Center of Prineville.
Okay, thanks, Rose. As Rose mentioned, we're really hoping to be in the house for the 4th annual Forum on Aging in Rural Oregon, but this little single-strand RNA virus disrupted our plans, to say the least. So today, Lee and I have revised our originally intended topic, and we want to talk about some of the impacts that coronavirus has had on our folks. And for those of you who work with the chronically ill, terminally ill, elderly, I don't need to tell you that these are the most compromised folks out there. And so we hope that our short presentation and the following discussion will spark some ideas for how we can continue improving what we do for other folks in other rural communities. Disclaimer, please note that the opinions you are about to hear expressed are those of your presenters and do not necessarily represent the views or policies of St. Charles Health System or Regency Pacific Management. Most of you have probably been following the numbers of COVID-19 cases in Oregon and in Oregon last 2 months. You need to get your life and get yourself and check out something more interesting. But as of last night, this is what the numbers look like. Now, most of us have a vested interest. We would like to see the numbers in our communities at a flat 0, but that is not the case. You are aware that Oregon has been comparatively spared the kind of onslaught that's hit places like New York and Michigan. Looking at the numbers here in Central Oregon, Deschutes County with 0.62 cases per 1,000 population is low compared to places like Multnomah County with 1.30 cases per 1,000, or Marion County with 2.64 cases per 1,000. So, yeah, we aren't 0, but we're low compared to some other places. Now, looking at Jefferson County, they're coming in at 1.0 cases per thousand. And so they're ranking right between Malheur and Morrow counties and just above the state average. Here in Crook County, up until this last weekend, we had been sitting at a single case for over a month, and then we had for us, comparatively a substantial explosion as a result of someone traveling from the west side of the Cascades into our county, who have been tracking the numbers are also aware that the risk groups for both infection and for fatality as a result of COVID-19 are the folks over 60 and those with chronic medical problems. In other words, people who look like Lee's residents or like our hospice patients. The first significant outbreak in the United States occurred in a nursing home in Kirkland, Washington. And as of the most recent OHA COVID-19 weekly report, there are 7 long-term care facilities in Oregon which have had outbreaks of more than 10 cases, and facilities currently account for about 10% of all cases and about 40% of all deaths. To date, neither Lee nor I have had any COVID cases in our respective populations.
To carry on with what Dr. Knorr has discussed, even though we've had basically minimal exposure to COVID-19 in our community, and none in our facility, fortunately, we were still confronted with the reality of dealing with a new virus, while we still had to deal with the winter flu season virus. I do want to say that the COVID-19 virus did impact our census. And as of this time, we show an 18% decrease. A couple of reasons come directly to my mind for the impact on our census. Number one and foremost is the lockdown in hospitals for elective surgeries and procedures. As most of you know, or may know, our primary referral source is from the St. Charles Hospital system. And so when that goes down, we go down. The second is due to the regulation of restricting visitations, including family members. There has been families that have chose to take their loved ones home so that they could continue to interact with them rather than place them in our nursing facility where their visitation would be restricted. Finally, I want to mention that, as Dr. Knorr alluded to, that the outbreak started out in Kirkland, Washington, in a nursing home. I definitely feel that there is a fear factor in admitting to a nursing facility, at least at that time and maybe even now, because of the possibility of admitting to a nursing facility will cause a demise of their loved ones. At this point, I want to note that Regency Prineville has had no positive COVID-19 cases. And I knock on wood as I say that.
Now, on the other hand, as Lee's census was going down within 10 days of Governor Brown's emergency declaration, St. Charles Hospice's average daily census increased by 15%, and it has stayed at that higher level. The other thing that I've noticed is that many of the folks that have been coming on to our service have been in duress. They have had uncontrolled symptoms, prognoses of hours, days, and so these folks have jacked up our acuity and our intensity. Most of our hospice patients have been living in their own homes and doing fairly well until shortly before they were admitted to hospice. Their rapid decline, their escalating symptoms translate into more frequent, more protracted, more intense visits from our staff. And needless to say, we were unable to abruptly increase our staffing by 15% over the course of 10 days. This is not the only time that we are going to be talking about staffing during the presentation. On the other hand, our skilled nursing facility patients have generally been significantly compromised for quite a while. And in many ways, a nursing home resident who qualifies for hospice admission, on the one hand, is probably one of the sickest people you can imagine, but things tend to unravel more slowly, more predictably. You can anticipate their decline and you can plan accordingly. So suddenly, our nursing home patients with surge in acutely decompensating patients became the most stable folks on our service. Now, required hospice services are specified under the Social Security Act and are regulated by the Centers for Medicare and Medicaid Services within the U.S. Department of Health and Human Services. Hospice professionals have certain care and documentation requirements with fairly tightly specified deadlines and frequencies to periodically ascertain whether or not our patients are indeed terminally ill. We need to be reviewing and revising each patient's care plan more frequently to make sure that the plan of care is consistent with the patient's condition and is aligned with each patient's goals. So if our access to our patients is restricted or disrupted, we miss some of these deadlines. And additionally, a certain proportion of our total hours are required to be provided by volunteers. A pandemic afoot, we cannot reasonably put our volunteers at risk for a communicable disease. So how do we meet the requirements of these regulations?
In particular to our situation, just when you get adjusted to the latest regulations, the regulation change. The establishment of a single point of entry to get into the facility was pretty easy, but the process of who to screen, how to screen, and what to screen kept changing. I think our screening tool changed about 4 to 5 times since this began. We have always had a process where we quarantine for things like flu or norovirus, but this new coronavirus was a new ball game, and it required a high demand on PPEs. And so stocking up on PPEs was a new challenge that we faced. And I'll warn you here, you'll hear a lot about PPEs throughout this presentation. But the challenge that I think that affected me personally the most was the restriction of visitation. This is one of the more difficult in terms of emotional support, not only for the family, but to the residents. This challenge required that we change our approaches and the ability to have families see and talk with their loved ones, and through a variety of mechanisms. So one of the ways we decided to deal with this is making a point person, and so we delegated our social service director to communicate with families and responsible parties regarding the changing conditions. Given the nationwide demand on PPEs, the facilities in our corporate network, we pooled our resources together to make sure no one facility would run out. We had weekly inventories to assess supplies and to send that up to the corporate network so they could determine who had what supplies and who needed what supplies. And of course, we held numerous meetings and did lots of individual and shift coaching.
Fortunately for us, the Social Security Act is so huge, so complex, so cumbersome that the rules stay fairly fixed. Now, as the CARES Act has been implemented and as CMS has been sorting this out, we think that they are permitting virtual visits for recertification, at least for the time being. The plan of care review, strictly speaking, doesn't require in-person visits, but our feeling has always been that this is best practices as we do this on a every other week basis. Now, in our case, Regency Prineville understands the importance of hands-on, eyes-on assessment, and they have continued to allow our nurse case managers into the building. As far as the volunteer hours are concerned, CMS has put those on hold for the time, and so far as a lot of the other regulations, they have told us that they are going to cut us some audit slack, at least for the time being. I doubt that any of us in rural areas suffer from having too much staff. All entities, we have limited staffing, and of hospices, with most of our patients residing in private homes, we also cover lots of ground. So given the 15% increase in our census, our nurses, social workers, chaplains, and aides have been spread even thinner than they were 3 months ago. For patients in long-term care facilities, it makes sense to collaborate with facility staff as much as possible. If the facility staff knows what our hospice needs to comply with CMS regs, they can us do some of the footwork by gathering much of the information in the course of their providing care to their residents. And likewise, our hospice staff, when they do go into the building, may be able to pick up some of the care tasks in the course of gathering information that we need to apply the CMS regs.
As maybe most of you know, we are required to report to the state agencies and to some of our regional officers when our residents are tested for infectious disease and the outcomes of those tests. If you're involved in long-term care, you probably have similar requirements. One of the things you need to have is an organized reporting structure and be able to delegate and designate reporters, as well as keeping meticulous records so that you know what you have reported and can refer back to those as needed. Hospice, I believe, has a different reporting structure. They cannot help long-term care with reporting, but knowing that they're expected to increase their visit frequencies in the final days of life may take some of the burden off your staff, especially nurses and nurses' aides. Make sure you and your hospice, local hospice, have a process for communicating the resident status and hospice visit frequencies.
This is probably a wasted question, and fortunately with you all muted, I don't have to listen to your answers, but has anybody's inbox suffered from a drought since the start of COVID-19? I thought so. On the hospice side, most of the regulatory noise comes from CMS in Washington, D.C. CDC also has a few guidelines regarding infection control for home health and hospice. We also have, and you probably also have, corporate policies and procedures. With the COVID-19 pandemic, infection control policies are being reviewed, updated, and disseminated. Travel and education processes, policies are being reviewed and updated. Policies on hours, working locations, documentation, reporting are all being reviewed, updated, or sometimes being written for the very first time. Usually good for at least one email a day. We get updates from our corporate office, and in addition, our professional organizations all have their own recommendations how we should be handling things and how we should be attending to our own self-care.
To continue on that, the nursing facility also faced that major challenge. We were confronted with numerous emails, directives coming from a variety of sources with the same message. The challenge being to filter through all that inbox messaging to determine what to pass on and how to do that. I want to stress that it's important to designate one person and an alternate to be keeping an eye on the Outlook box, to have that person summarize the information and communicate that to the staff or those that need that information. You don't want to get things missed in this type of environment, and you don't want people assuming things that have not been clarified. And you don't want your staff to go through spending hours sifting through the emails to get that information. In my case, I took a task on myself, but that doesn't mean you cannot delegate someone else to do that.
Now, on our side, our hospital system set up a daily incident command meeting when COVID was first threatening to hit Oregon and before the governor's declaration. Because our hospice patients are not generally in one of the hospitals, there was the possibility that home health and hospice might be overlooked, and we made sure that that did not happen. Our director was one of the folks sitting at the table, and she took it upon herself to give us daily updates during our morning staff huddles. And each afternoon, the incident command team would send out its own emails. So here are some general suggestions for dealing with the static. There is no one-size-fits-all approach. You know your organization, you know the people you work with, and as Lee said, please don't do things the way that we do it just because that's the way we do it. Lee called his own number as far as being the email point person. If you're a long-term care facility director, please feel free to delegate. And just because we have a morning huddle at hospice, please, please, please don't go starting one just because that's what we do. Give your email point person the authority to hit delete. As Lee said, a lot of this stuff is redundant, and you have to be reading the same thing 6 times a day. You need to figure out how to sort through the stack, pull out what really matters, eliminate the redundant, and communicate an effective summary to your staff.
At Regency Prineville, it's our primary goal to give our residents and patients the best care we can give them. None of us wants to be sloppy with our approach and put people at unnecessary risk. Our staff is accustomed and trained to monitor for influenza each winter, but now we have to monitor another virus as well. We need to be aware of what our patients and residents might be exposed to, where they might be exposed, and to do our best to minimize that exposure.
Prior to COVID-19, our volunteers used to deliver medications, deliver flowers, stop in to cheer up patients and their families. And as I mentioned before, most of these activities came to a screeching halt with COVID-19. Specifically related to this presentation, we are no longer, at least for the time being, sending our volunteers into facilities. We now have our professional staff delivering medication on their scheduled visits, and the cheerful bouquets probably not going to be coming back for a while. We previously assigned patients to nurses, aides, social workers, primarily based on the patient's location and each caseload. We now have another factor to consider, that we are trying to make sure that there is only one team, nurse, social worker, aide, chaplain, going into each specific facility. We wanted to help the facility limit the amount of traffic in and out of their buildings, and introduce another wrinkle in assigning patients. Always carried hand sanitizer. Masking, gloving, hand sanitizer enable us to help with this facility compliant with CMS and DHS regs. We are going to be talking more about masking when we get to slide 22.
With all the regulations and things that came with the advent of COVID-19, all new admissions were required to be tested for SARS-CoV-2. Rather than making our staff make a choice of who gets tested for which virus, if a resident was being tested for regulatory or symptomatic reasons, we tested for both. Our isolation requirements for residents coming into the building or returning to the building were already in place. To reduce the exposure risks from non-residents coming into the building, we restricted visitors. And by the way, that was also mandated, and so, but it was for a good reason.
One of the biggest benefits for me in assembling this presentation has been gaining a better understanding of Lee's regulatory and operating environment. My organization has policies on infection control. His organization has policies on infection control, and COVID-19 has given us incentive to review and update these policies. Perhaps we could borrow things we like from one another's policies if our corporate leaders approve, rather than reinventing the wheel. please don't wait for another pandemic before you review your policies. One of the advantages of living and working in a smaller community is the opportunity to actually know the people who belong to the voice on the other end of the call or fingers that just generated that tweet, text, or email. This may be especially important in the setting of a pandemic when things are changing rapidly, when you and your agency are not the only ones affected. I know where Lee's office is. He has my cell phone number. I have his cell phone number, and no, I am not going to give out Lee's cell phone number at the end of this presentation, but I would encourage you to make similar connections in your community if you have not already done so. When we step into Lee's facility, we can anticipate a clean environment, pleasant, helpful staff who are caring for our patients. We don't have to worry about that friendly pit bull running loose, or the hoarded newspapers stacked to the ceiling, or the primary caregiver, or encountering feces spread over most horizontal and vertical surfaces. Not many of our patients' homes are like that description, but we have seen a few over the years. As previously mentioned, most of us recognized as SARS-CoV was on its way across the Pacific Ocean that PPE was going to be tight. If your hospice is totally unattached and freestanding, you get to call your own shots, write your own rules, and order your own supplies. Let's be honest about it. Most healthcare system infection control strategies focus on care in facilities owned, operated, and maintained by the health system. And it may have been a while since policies have been reviewed. If your hospice or your facility is part of a larger system, your PPE will probably pass through a centralized supply in a larger facility, in a larger community, and through the hands of someone who really doesn't know what you do or what you need.
Dr. Knorr, it's always good to hear that Regency Prineville presents the kind of environment you'd like and we'd all like to have your St. Charles Hospice patients living in. One big challenge since the governor declared a state of emergency back in March has been keeping up and keeping enough PPE on hand. As I mentioned back in slide 9, the Regency Pacific system decided a couple months ago to begin tracking usage and inventorying, pooling resources, and allocating supplies where they are needed.
Even under normal circumstances, we cannot afford to have staff members out sick. So keeping our staff healthy has been even more important in view of the increased census and increased acuity. St. Charles issued its first guidance on in-home visits Monday, March 2nd, 6 days before the governor declared a state of emergency and 9 days before the first COVID case in Central Oregon. We were encouraged to consider whether a virtual visit, an in-person visit, and if an in-person visit was in order, our staff and calling ahead to ask if the patient or anyone else had a fever or shortness of breath. If our patient is in a facility, a virtual visit is probably more feasible, and facility staff are now screening at the bedside for the same things we screen for the phone. Our offices are now set up to maintain physical distancing. I have been doing most of my work from home since early March, and Charles is still encouraging us to work from home as much as possible. Virtual huddles, virtual weekly interdisciplinary team meetings, and have been since mid-March. Universal masking is a St. Charles policy. We're wearing cloth masks in the office, surgical loop masks during patient visits and N95 masks when performing aerosol-generating procedures when a patient, family member, or caregiver has been documented or has suspected COVID-19. Protecting our patients is one of the reasons for masking and pre-visit screening, but for a small rural agency that does not have plus staff and not knowing where our co-workers have been in the course of a day, protecting our staff may be an even more important reason.
Well, I said we're going to be talking about PPE a lot, and I think Dr. Nora just kind of alluded to the fact that why and how frequently we use those PPEs. In the facility, every time a new resident comes in or a resident goes out and comes back in and goes to the doctor's office and comes back in, they're subject to a 14-day quarantine, which means full PPE, donning of full PPE. And with that said, I do want to stress that the importance of establishing, updating, and communicating your policies, including PPE policies. They're so easy to overlook, and we have to constantly remind our staff that that is important. I also want to address the governor's reopening guidelines, and I'm going to quote her, quote, "Large hospitals and health systems in the region must have a 30-day supply of PPE, and rural or small hospitals must have a 14-day supply," end quote. Governor Brown is addressing hospital PPE supplies, but I think those of us, including hospice, that are involved in rural health care, and those of us caring for the frail, compromised, chronically and terminally elderly, know that we are out at the end of the supply chain. My recommendation is that you have more than a 2-week supply on hand. We at Regency Pacific, Prineville, are shooting for a 2-month supply.
Perhaps the most challenging part of the COVID-19 experience, as Lee alluded to earlier, has been giving families the assurance that even though their loved ones are approaching the end of life, they are comfortable and well cared for. They've read the news reports of outbreaks in nursing homes. They've seen the film clips of families in parking lots trying to communicate with mom or dad through a closed window, and they just know those hospice people are the buzzards of death. Those of us in the healthcare also know that bad news sometimes may be better than no news at all.
I'm really pleased and happy that Regency Prineville and St. Charles Hospice have adapted really well to the constraints put on us by this pandemic. We allow families direct access and have made the logistical adjustments to facilitate those visits without putting our other residents at risk. I think Dr. Nora alluded to sound like window visiting, but there's video chats, there's other forms, cell phones, other forms that we're using to make that happen.
And as I mentioned earlier, our chaplains, social workers, and other staff are required to increase their visit frequencies during the final week of life. In addition, they're making phone calls to field questions and concerns, reminding families that their loved ones are receiving excellent care, and assuring them that our staff and we staff are coordinating care. There are if you could make it up to Regency right now, phone calls that nobody likes, but hopefully we have let families know how patients are doing so that these calls don't come as a complete surprise. Families need to be assured that the left hand knows what the right hand is doing. If you're with a hospice leading off your phone call with, I'm here at Regency, I just saw your mom, or if a facility leading off with, Ginger was just here to see your dad, can be huge. Given that none of us in rural communities suffer from surplus staff, setting up a tag team arrangement between hospice and facility staff to alternate calls to families stressful times to facilitate more frequent communication and spread the phone time workload around. Most of us in Oregon are now in phase 1 of reopening, so is this discussion even pertinent anymore? Our personal hunch, and that of many epidemiologists, is that we will be getting hit again in 6 months or less. I hope I'm wrong. We hope I'm wrong, but we should be prepared just in case.
I think preparation is the key, whether it happens or not. And right now, we have the opportunity to sort of catch our breath, clear our heads, and regroup. We hope today's discussion has been useful and helpful to address some of the challenges that have come along and will come along, and for helping us to prepare for the challenges that are yet to come.
Remember that we, St. Charles and Regency Prineville, began gearing up before the governor declared a state of emergency and before there were any cases in Central Oregon. Those of us in rural areas accustomed to working without surplus staff and without huge inventories, time is our most precious commodity, and anticipation is our most effective tool.
All right, so if there are any questions from the audience, please type them into the chat box and I will read them to our presenters. So I'll give you a couple of minutes to put your thoughts into words, and I will go ahead and get started with one question for you all. Dr. Garber, how are your protocols being developed now, and how will those impact what you kind of left off by saying what will most likely be a double wave of flu season?
Refine your question a little bit more, Rose. In terms of protocols, St. Charles pretty proactive. As I indicated, we advise our infectious disease procedures. We did have a pandemic policy already in place, and now we actually have a pandemic, and so we've looked at that to make sure that that's really up to speed. In terms of the things coming at us, continuing to keep an eye on CMS.
Great, thank you so much. And Lee, you mentioned that you have assigned one person, which is yourself, to retrieve information and collect it and then present it back to your team, and that you do it in a staff huddle. If it weren't the director or medical director of an organization, who would you suggest would be a good fit for this role?
Well, I think there's a number of people you can delegate to. For me, the second person would be the Director of Nursing Services. She not only gets CC'd on many of the emails, but beyond her, I'd also look at the Social Service Director. She's already in communication with the families and responsible parties, and we do that weekly. So both of those are two point persons who could handle the position.
Lovely, thank you.
Okay.
Dr. Neuer, you mentioned that the hospice census rose as long-term care censuses dropped. Do you know or have any hunch as to why that may be?
Well, I think Lee addressed why his census dropped with the with elective procedures being put on hold and with the public perception that nursing homes were at increased risk. In terms of ours, and this is totally personal perception, a lot of folks will postpone going on to hospice because, again, they just know that we're the buzzards of death, and we hear people say, "I'm not ready for hospice," or "I don't want to come on hospice. I want to fight this thing." But my sense is that with COVID-19 hitting the United States, people started to realize that if I get this critter, I will probably die. And as a matter of fact, come to think of it, even if I don't this critter, I'm probably going to die anyway. And so it was a good reality wake-up call.
Thank you. So it sounds like, relatively speaking, you've had a pretty smooth sailing process out there in Prineville. For other organizations that may be just experiencing this situation or not having had such an easy experience, what, from each of you, Dr. Noor and Lee, what would be your greatest advice moving forward, especially as we progress in the next few months?
Given that we don't have unlimited staffing, unlimited time, please don't reinvent the wheel. And you put our contact information up there, and even though my in-basket and Lee's in-basket are not starving for want of communication, if we can help you out with some of our ideas, please don't hesitate to contact us. The other thing that I think is probably going to be the biggest benefit of this event is that it's conversation. People can exchange ideas, and we can help one another through the whole process.
Well, my thoughts are this. I think we have the advantage of experience in terms of we've gone through this, or at least we're going through it. And like Dr. Noor said, we have already set up a number of things to deal with the challenges that come. Now, I know different settings are, not exactly like ours, but I think the principal basics will be the same everywhere. That's preparation of having PPEs if your environment or situation will involve that, and to communicate with others that are in similar situations to see what they're doing and be ahead of that on the curve so that you're not waiting and wondering, well, what happened? You're going to be on the forefront, knowing what happened and what other facilities have experienced, and use their experience.
Great, thank you. So both of you mentioned a great deal of pertaining to regulations, and are there any regulations that need to change, in your opinion, in light of COVID-19? And have there been regulatory changes that have been helpful and that should be kept after the pandemic's over?
The topic that Lee and I were originally going to present was called "What I Wish Every Clinician Knew." We were going to talk about the regulations in depth. We don't have time to get into that specifically right now, but I know in our situation, especially with regard to the virtual face-to-face recertification visits, still being worked out. So again, as Lee just said, communicate. And Lee and I both try to stay on top of the regs. So if you're in long-term care, send your emails to Lee. If you're in this, send your emails. If you know somebody who is even better versed in the regulations, don't hesitate to get a hold of them, because things are changing literally every day.
I wanted to say that I can't think of a regulations that's been placed on long-term care that's I can actually say is not necessary. I think one of the regulations that causes me the most pain in terms of emotion to our residents and their families is the visitation rule. I wish we could find a way where we could make that happen on a more frequent basis and yet keep it safe for everyone. But other than that, I don't have any strong recommendations.
Beautiful. Well, thank you, Dr. Noer and Lee, for joining us today and sharing about your experiences with COVID-19 and hospice and long-term care out in Prineville. We're at the top of the hour, so I want to thank everybody for being here today, and we will catch you next time. Thanks so much.